putting the device in, and we are closing the pocket with 3 layers in with single suture, that is vital 20. So I am sharing my experience as well as study. So coming to the introduction, as we all know, that pocket infection is the most feared complication of the implantable devices, and more complex CIED system implanted, the higher is the infection risk. So there are numerous studies. The incidence report is 1 to 12.7%. It is infection is even higher with the devices which are more complex, like ICDs. And from there, if we increase to CRTP, then it is 9.5% with CRTDs. So it increases with the complexity of the device, because the procedure time is also more with the complex devices. So mostly pocket is closed using interrupted absorbable sutures for subcutaneous tissues and non-absorbable mattress sutures for skin, or using staples. So that is the common method. But here what I am presenting is my experience with the using only single absorbable subcuticular suture of vital 20 with all 3 layers at various centers in the armed forces and in civil. Total experience is for 565 cases of last 6 years. So aim of the study is to study the effectiveness of the pocket closure and observe incidence of pocket infection and device explantation using single absorbable subcuticular suture, that is vital 20. And also another aim is to compare with the other alternatives available. So coming to the materials and method, so it's a multicentric single operator observation study. So depending on the place of my posting. So study period is from January 2017 to December 2022. That is for 6 years. And total 565 patients who underwent cardiac implantable defibrillators or devices for various indications were included in this study. And in this 564 cases, pocket was closed using 3 layers of single absorbable suture, that is vital 20 was used. While in one case, monocle 20 was used due to non-availability on shelf at that time of Vicryl. So ASCD single chamber implantation were 54, pacemakers were 151, dual chamber ICD was 58. That is total 365. All devices of different kinds were there, including CRTP and D. So grand total was 565. So age range from 4 years, that was the minimum age in which I used this suture, to 92 years, that was the maximum age. And coming to the average, it is 66.1.16 years. So 40% were females, and rest 57% were male. So 154, that is 27% patients were diabetics also. So and antiplatelets, dual antiplatelets also patients were around 14.5%, and 3.36% were also on oral anticoagulants at the time of device implantation. So my post-op protocol is antibiotics. I am giving either teicoplanin or linezolid plus amikacin or ceftriaxone. That is weight and creatinine clearance based dosage. And first dose is given 1 hour prior to taking to the surgery, taking for the operation. And combination is initially given for 5 days. And after that, another 5 days, we are giving oral antibiotics. That is, most commonly, we are giving septum and linezolid for another 5 days. Total period is antibiotics we are giving it for 10 days. So wound care dressing is first dressing is done on day 3. Most of these patients are discharged on second dressing, that is after 5th day. And 95% of my patients were discharged on the after second dressing, that is on the 5th day. And total antibiotics, IV antibiotics were also completed by that day. So average hospital stay in our study was 5.7 days. So coming to the pocket infection incidence, it was seen that only 22 patients, that is 3.8% patient got infected, pocket got infected. And most of these patients, the risk factor was that they were either diabetic, or they were on anticoagulation, or they were on antiplatelets. So all these patients, all 22 patients, out of them 17 were diabetic. And there was no mortality, and we saved all the patients. And minimum follow-up is of 6 months, and maximum is 6 years. So 10 of these patients in which pocket got infected, infection was only superficial, that was confined to skin, and it was not communicating with the pocket. So it healed with the prolonged course of antibiotics and dressing. 1 extra week of hospitalization was required. That's why average hospital stay was 5.7. In rest 12 patients, with the help of reconstructive surgeon, we used a novel technique. That is, we put a same device in the subpectoral pocket with the negative pressure wound dressing, and 9 of these devices could be salvaged. So only 3 explantation were required. When both the approaches were unsuccessful, only then we went for the explantation. So device explantation rate was only 0.7%. And final, because only 4 patient devices were explanted, and device explantation was required. And what we did next day only, on the contralateral side, we put the new device. So in that, old devices were discarded. So total, out of 4 patients, only 3 patients with Vicryl 20 had explantation, while monoclonal 10 was used only in 1 patient, and that patient underwent for explantation. So overall success rate using 20 Vicryl was 99.47%. That is the highest in any of the study. So this is the other advantage is that look-wise, it looks very good, because this is the immediate look when we finish the post suturing. There is no suture mark. This pocket is closed very good. It's a healing can be predicted that it should be good, because all the edges have been closed properly, and there is no gap. There is no gaping. So similarly, when patient come for first day after dressing, this is how it looks on the day 3 when first dressing done. This is on follow-up. That is after 3 months when patient is coming to us on follow-up. This is how it looks like. So you can see that there's just very minimal scar mark, and it nobody can, especially females are preferring this approach. And if we compare with the other methods, what we are using, either this subcuticular sutures, this thing, sorry, this subcutaneous sutures are used, mattress sutures, or somebody were putting staples. So this is how it looks after the first dressing, and this is how it looks on follow-up. Sometime that is the worst case. Patient may develop keloids also, but it never in our patient, none of the patient develop keloid. So to conclude, in our experience using this Vicryl 20 suture, only 3 out of 564 patients, that is only 0.53% devices were explanted, and rest all pocket healed perfectly well with the success rate of 99.47%. That is the highest in any of the studies. So monoclonal 20 has not been found to be a good suture in our study, although only 1 patient it was implanted, and that too he underwent for explantation. So secondly, we also found that device salvage therapy using subpectoral pocket and negative pressure wound therapy with the help of reconstructive surgeon was success rate was 75%. In this, I want to mention that devices which have been implanted outside our hospital, and they came with the pocket infection, or device was visible outside the pocket. So in that also, when we use this approach, we save many of these patients from explantation, device explantation, and same devices were successfully implanted. So cost of change of devices was also not there. So in our patient, so patient on the average saved around 4.5 lakhs by using this procedure. So another advantage is it gives aesthetic looks as shown, and hospital stay is also reduced. With the other method, we have to remove the suture at 10th day and 14th day. So patient has to be for in hospital for at least for 10 to 14 days. So here our hospital average hospital stay was less, that is 5.7 days. So overall, therefore, pocket closure technique using single absorbable suture, that is Vicryl 20, extremely safe and useful, as well as it is very cost effective in reducing the pocket site infections. Thank you. That's all from my side. If anybody want to ask questions, I'm open for that. Any questions for me?